Thank you very much for the very kind introduction, and thank you so much for this wonderful invitation to come back to Hyderabad. I still remember the last time when I was here, and I have very, very fond memories of the hospitality, the wonderful food, and the beautiful sights. So thank you so much. I would also like to echo what Professor Mehta already said, that it is a great opportunity to learn from each other. And certainly when I was here last time, I learned a lot from the speakers and the discussions with members in the faculty, in the audience. So thank you to everybody for sharing their knowledge. So in the next 20 minutes, I will talk about anticoagulation. And it follows very nicely from a talk on vascular access. These are my disclosures, but they have not influenced what I'm going to say. This is the artificial kidney. And clearly this is where clearance occurs and where excess water gets removed. And it is pretty amazing when you look at a filter that the blood gets through these tiny little fibers and we achieve clearance and fluid removal. Now, premature filter clotting can obviously occur, and it's a real headache. When it occurs, then for a start, patients don't get the treatment which they were intended to get. They may also lose some blood and may need an extra blood transfusion. And for the healthcare providers, in particular the nursing staff at the bedside, it undoubtedly increases their workload, and it raises alarms, and it makes the whole situation very noisy and distracts from other important duties. As I've already mentioned, the filters have thousands of these tiny little fibers, and they're almost hair size, and it's pretty remarkable that the blood gets through and that clearance occurs and excess water can get removed. But it comes as no surprise that tiny blood clots may form, because it's obviously artificial material, and blood will be in contact with artificial material, and this may trigger thrombosis. And here we have the inside of one of these fibers in a patient who was actually receiving heparin. You can see that despite appropriate anticoagulation with heparin, some thrombosis can be triggered and platelets can be activated, forming these nets of fibrin, platelets, and red cells. So it's the artificial material, it's the fibers which trigger thrombosis. But another important aspect is obviously that hemoconcentration, or the blood gets hemoconcentrated as the blood flows through this filter, and that's as a result of fluid removal. So we have two main reasons why the filter may clot. In addition, there could be additional factors in individual patients. In some patients, there may be problems with the circuit, and the blood may be in contact with air, for instance, in the drip chamber, and this is prothrombotic. There may be patients who are already prothrombotic to start with as a result of an underlying problem, for instance, sepsis alone, but also they may have a hematological problem making them prothrombotic. Then they may also receive other medications or lipid infusions, TPN, propofol, that increase the viscosity of the blood. And then lastly, if the flow through the circuit is impacted and not very smooth, then the blood could clot much quicker. And that obviously brings us back to the first talk. So with poor vascular access and blood flowing and then stopping, the risk of circuit clotting is much higher. So we want to prevent filter clotting. We want to prevent the formation of tiny clots in the filter. And I'll just bring up this slide here just to say filter clotting is different from filter clogging. Filter clogging just describes the formation of a protein layer within the filter, and this cannot be prevented with anticoagulation. So the aim of anticoagulation is to prevent the filters or the fibers from having tiny blood clots formed inside. And we want to do this so that we can deliver the prescribed dose as per prescription. We want to minimize blood loss, and clearly we want to make the life easier of the caring staff at the bedside. And lastly, if you prevent premature filter clotting, you will also reduce costs. Now, the options to keep the filter going include anticoagulants, but also simple things like if you don't have anticoagulation, some regular flushing, so hemodiluting the blood before pre-filter. Now, this can be done and is effective to some extent, but it clearly doesn't inhibit the clotting cascade. If you want to really prevent clots, then we need anticoagulation, and the current forms of anticoagulation include heparin, prostacyclin, regional anticoagulation, and some other anticoagulants, in particular thrombin inhibitors and factor Xa inhibitors. But importantly, they can only be effective if you've got good vascular access. So the key of filter patency is good access. And anticoagulants do not substitute for poor vascular access. I'll just go through the various anticoagulants. And I've already mentioned it is possible to improve filter patency by giving regular flushes pre-filter. It's only one randomized controlled trial, and it did show that filter life was slightly better in patients who had received regular flushes pre-filter. We have used it in our unit. The nurses don't like it very much. It certainly increases their workload. And when done regularly, so every 15-20 minutes, it did keep the filter going in patients who really couldn't have any anticoagulation. But it has to be done regularly at short intervals. And as I said, only one randomized controlled trial was conducted, but it did show some positive results. It's much more common to use anticoagulants, and certainly unfractionated heparin remains the most commonly used anticoagulant worldwide. Heparin, unfractionated heparin, works by activating antithrombin 3. And when you do that, you essentially inhibit all the various factors that are here in red boxes. Unfractionated heparin has many advantages. We're all very familiar with heparin. It is widely available worldwide. It is relatively inexpensive, can be monitored, and most doctors and nurses have experience with it. But it has some potential challenges and risks, undoubtedly. It will lead to systemic anticoagulation and increase the risk of bleeding. It has unpredictable kinetics in patients with kidney disease, acute kidney injury. And it can also increase the risk of heparin resistance and HIT, which will then cause thrombi and increase the risk of filter clotting. Low molecular weight heparin has a more reliable kinetics, but has been less studied in patients with acute kidney injury. But there are no protocols for the use of low molecular weight heparins, and enoxaparin and nadroparin have certainly been described in the literature and been used successfully. Another anticoagulant that's been used is used worldwide, and certainly we used it before we used citrate, is prostacyclin or epoprostenol. And it's often indicated in situations where clinicians want to avoid heparin or have to avoid heparin. It's used as a substitute for heparin, but importantly, it's only a very weak anticoagulant because it does not affect the clotting cascade. It only affects platelet activation and inhibits platelets. The antiplatelet effect is relatively short. As a side effect, it has to be remembered that it's also has vasodilatory properties and therefore could lead to hypotension and increase the risk of hemodynamic instability during CRRT. And often, certainly in our experience, patients ended up either being started on noradrenaline or on higher doses of noradrenaline. But it's still used, and it's particularly used in the UK in liver units, where where clinicians want to avoid heparin and also feel uncomfortable using citrate. But it is a weak anticoagulant. And then we have some alternatives that have been used. So we have some fondaparinux, for instance, is a factor 10A inhibitor, or direct thrombin inhibitors. So in the UK, agatroban is available, but in other places, bivalirudin is more commonly used. And as you can see here, they have different half-lives and different forms of being metabolized and eliminated. And clearly, whatever anticoagulant clinicians use at the bedside, it's important to have the relevant background information so that you are prepared and know how long the drug will be active for, whether an antidote is available, and how they get metabolized. Now, lastly, I want to talk about regional anticoagulation, and I feel slightly embarrassed that I'm talking about citrate, when in fact Professor Mehta, sitting next to me, is the person who developed the citrate protocols and was the first to use citrate for regional anticoagulation in CRRT. So Professor Mehta actually has developed these programs. We use it thanks to him being a genius in this area. But it has now become a form of anticoagulation used in many places worldwide, and it's currently recommended as the first-line anticoagulant for CRRT in the latest KDIGO guideline. So citrate, here we have a molecule of citrate, and it has the ability to chelate calcium. Now, if you think of calcium, then you will remember that calcium has an important role in the clotting cascade. And as you can see here, it acts as an important contributor to the clotting cascade at many steps. If you add citrate to blood and chelate calcium, then the clotting cascade will be inhibited at multiple steps, as shown here. And if you give enough citrate so that the ionized calcium level drops to below 0.3 millimoles per liter, then clotting is completely inhibited. The clotting cascade is completely inhibited and clots cannot be formed. And we know this from various studies, but essentially you have an infinite bleeding time with an ionized calcium concentration of less than 0.3. And essentially, that's the background to the existing citrate protocols. I will not go into different protocols because many different protocols exist now, thanks to different citrate formulations being available. But the principle is very similar, and they all use the same principles. Essentially, citrate is added pre-filter, and enough citrate is added so that the ionized calcium concentration of the blood, as it goes through the filter, is around 0.3 or less. This means the blood cannot clot as it flows through the filter. Calcium is added just before the blood returns to the patient, with the idea to normalize the calcium level in the patient. And this means the blood is only anticoagulated as it flows through the filter, and the patient has a normal calcium level and is not anticoagulated. The citrate anticoagulation gets monitored by monitoring the post-filter ionized calcium concentration and by monitoring the patient's systemic ionized calcium concentration. And for the patient, obviously, we aim to keep it in the normal range. Citrate has a beauty in that we already have citrate in our body. We all have citrate in our mitochondria because it's part of the Krebs cycle. When used as an anticoagulant for CRRT, about 50% are removed directly as with the effluent, and the remaining around 50% are eliminated by the Krebs cycle, predominantly in the liver and in skeletal muscle. In health, citrate also gets eliminated in the renal cortex, but that's less relevant in patients with acute kidney injury. And here you have the Krebs cycle. So citrate is an essential component of the Krebs cycle in the mitochondria. If patients receive citrate anticoagulation, then additional citrate is added. In health, we have a very small amount of citrate in our body. But when citrate is used for anticoagulation, when the citrate calcium complex breaks down again, calcium gets recycled, and citrate gets used to produce energy in the mitochondria via the Krebs cycle. This also produces bicarbonate, and this obviously helps correcting the metabolic acidosis in acute kidney injury. As I've already said, there are now numerous different formulations available, depending on by different commercial companies. And the protocol, the exact protocol, i.e. how much citrate to give and how much calcium to supplement, depend on the specific citrate formulation. Now, citrate has been compared with heparin in many different randomized controlled trials, and we have several systematic reviews in the literature. I'll just show you one here from a few years ago, which included the data of 14 trials, and they looked at the efficacy of citrate, but also potential side effects. And essentially, as you can see here, there was a clear signal in favor of citrate. The most recent evidence stems from a randomized controlled trial conducted in Germany by Professor Sarbock, where they enrolled almost 600 patients to citrate versus heparin, and clearly showed a difference in filter life. Filter life was much longer in patients who had received citrate. There was no difference in mortality. As already mentioned, the most recent meaning 10 years old KDIGO guideline recommends citrate as the first-line anticoagulant for CRRT and heparin for intermittent renal replacement therapy. And then lastly, I just want to really emphasize and support what we heard in the first talk. Anticoagulation is only effective if you've got an adequate line, if you've got the right size line in the appropriate vessel and of appropriate length. Any lines which may be kinked or may be bent or may have less ideal sizes and designs will lead to turbulences, which may trigger hemolysis and the formation of clots. And this was an important outcome of a systematic review where they looked at filter patency and filter life. It's not just the anticoagulation, there's so many other factors that contribute to a working filter. Some are the aspects related to the techniques, the access, the circuit, and then obviously human factors, monitoring and acting on the results. And with that, I want to finish. So premature filter clotting is a real problem in clinical practice. Maintaining filter patency is essential to deliver the therapy which we believe patients need. The recommended anticoagulant, first-line anticoagulant for CRRT is currently citrate based on the existing data, and it offers regional anticoagulation without anticoagulating the patient, but it only works if you've also got an appropriate catheter in the right vessel and a catheter of the right design and length. Thank you for your attention.